we have some other striders, we're just kind of catching those. So first of all, thank you for coming. Hopefully you guys are here for the alternatives to opioids as far as chronic and acute pain. We'll cover both of those. They have a little bit different approaches depending on whichever one we're dealing with. And to give you an idea of my background, first of all, one of the reasons we're here is because the Chandler Committee for Youth Substance Abuse, which is part of ICANN, has put together a variety of approaches to helping combat the opioid epidemic. And we now have that from the nationwide down. Unfortunately, it's just our nation. It doesn't seem to be happening in a lot of other countries. And the statistics are a little bit scarier, They actually became scarier. As of last Friday, they kind of readjusted the numbers based on death certificates, and our numbers got a little bit higher as far as the incidence of deaths associated with opioid use. And so most everybody now, it's very easy to find statistics on what's going on. I won't cover that. We'll kind of jump right into what we can do so that we don't become a statistic or contribute to them. As it says up there, my name is Dr. James Bogash. I'm a chiropractic physician. I've been in practice for almost 20 years now. And practice in Mesa, just right out of Alma School in 60. For the past 20 years or so, I've managed to read on the range about 120 medical journals a month, always looking for things related to natural medicine, wellness care, disease prevention. Physiology, or how the body works, is my passion. And unfortunately, there's a huge gap between what we know in the research and what happens in a typical doctor's office. The lag time's about 20 years. In some cases, it's a little bit more. So one of the things I try to do is bridge the gap and bring things into the community in my office today, instead of waiting until it's our kids or grandkids to get an opportunity to get the benefits from whatever it is. Now, can everybody hear me okay? Okay. So we'll get started. Since it's a smaller group, if anybody has any questions as we go along, don't hesitate to raise your hands. If not, we'll kind of address them at the end. Or if there's something I say that you need a little bit of clarification, don't hesitate to wad up a sheet of paper, throw it up front, do whatever you need to do to get my attention. So, again, I won't go into detail on the opioid crisis, but it basically comes down to three problems for alternative management on cancer pain. Is what to use for an acute episode, because we're using opioids for acute episodes when it's not really the appropriate time to use them. What do we then use for chronic pain, which the data isn't very good on opioids for chronic pain either. And we're talking about non-cancer pain, that's an important factor. It's not necessarily the cancer pain that we're looking at using things like Dilaudid for terminal patients. It's a different discussion than what the opioid crisis is today. And then what do we use for those coming off of opioids as a result of treatment? These patients will still have the pain that led them to needing the opioids in the first place. So what do? They're now left without whatever they have been using for pain control as effective, whether it was effective or not, they still need other alternatives. A lot of that falls under the chronic pain, so we'll kind of blend those two together. But we'll start with acute management. And we'll start with NSAIDs, non-steroidal anti-inflammatory drugs, your typical ibuprofen, naproxen, the thing that there's hundreds of commercials pretty much every week that you need to see. A couple things to understand, that we now know that we shouldn't be combining any NSAIDs with anybody who has pre-existing heart condition. That is something that I still have a lot of patients coming in who have had heart attacks or have had cardiac procedures, and they're still given NSAIDs. And those now are contraindicated. You should not be giving NSAIDs in a patient with a pre-existing heart disease. And I would suggest that anybody who's pre-diabetic, which has some pretty strong links with heart disease, that anybody who's pre-diabetic should not be given NSAIDs as well. A lot of that all started from, do you guys remember the Vioxx debacle back in the 10, 15 years ago? And where they found that Merck had actually suppressed some of the data that they knew that Vioxx was contributing to heart attacks. And Vioxx Bextra and Celebrex were all a special class of drugs that was only designed to block one enzyme for pain and not the enzyme that affected the GI tract and healing for GI tract. So the idea was that this would be a safer class of drugs for the GI tract, less risk for ulcer. And so we started using these quite frequently, and they were expensive drugs, and then we started finding out that they were contributing to heart attacks. The problem then was, if we realized that these special NSAIDs contributed to heart attacks, what about all the other NSAIDs? And when we stepped back and looked at the research, the answer was yes. They absolutely contribute to heart disease. And so now, anybody with pre-existing heart disease should not be taking any of these types of classes, anything in this class of drugs, which doesn't mean that they're not, it's just contraindicated. My personal thought on these, I'm not a big fan of anti-inflammatories. If they're going to be used, they should be used short-term only, first 12 to 24 hours. I consider inflammation as considered a hill that we need to go over. It certainly makes sense to make sure that that hill is lower in the first place. So that's why things like ice and ibuprofen in the short run may keep that hill a little smaller because it stops inflammation from building. But after that first 12 to 24 hours, we want inflammation to run its course. And a lot of times, things like prolonged use of ice or anti-inflammatories will absolutely interfere with the entire healing process. Just in case that sounds strange, anybody who's had a rotator cuff repair in the past 5, 6, 7 years, they tell you that you cannot use ibuprofen or anything in those classes of drugs because it interferes with the healing process. That surgery will not, the outcomes will not be good. So if that happens after a surgical, what about any other injuries that we have? To me, it makes sense that it's going to interfere with the healing process just as much as it did with that rotator cuff surgery. I personally, despite having numerous martial arts injuries over the years, I haven't taken anything in this class in probably 25 years, and probably longer. So that's elbow dislocations, backs thrown out from helping friends move. I never felt the need to take anything along those lines. When we start getting into supplements, the proteolytics, if you've ever heard of like Wobenzyme, they always end in kind of like an enzyme type of name or a zyme type of name. They're called proteolytics, and they're designed to help break down the proteins involved with inflammation. The problem is that they're expensive, and so it's hard for me to tell a patient they need to take $30 worth of this proteolytic enzyme versus 50 cents of an ibuprofen if they're hurting after an acute injury. So it's somebody who has to be really dedicated to staying away from drugs to look at proteolytics for like an ankle sprain or a back sprain or something like that. Turmeric certainly has some pretty stellar research on it. Generally better for chronic. We'll cover that a little bit more when we get into the chronic side of tonight's presentation. So what do we do after an acute injury? We usually recommend ice for the first 12 to 24 hours only. Again, we don't. So ice actually slows down the amount of inflammation on the front end. And after that, I generally recommend moist heat. I have patients all the time that tell me, I'm like, well, what are you doing? Oh, I've been icing it. Well, what makes it feel better? Oh, a hot shower. And for some reason, we have this fear of moist heat. Just had a discussion with a patient today because she thought that the moist heat would actually inflame those tissues more. And unless you're microwaving something for 45 minutes and then putting it on bare skin, moist heat will not create inflammation. As a matter of fact, after that acute inflammation stage, we want more blood flow in, we want waste products out. And moist heat will actually promote that, so that you want that exchange of blood that moist heat provides. Ice will shut down blood supply. And so after a period of time, you start reducing the ability to deliver these nutrients, healing nutrients, to an area. So a TENS unit is it's a little device. Some people in this room will understand this, some people won't. It looks like a Walkman. And so, or a giant, like it's an iPhone 7, about the size of, that's for the younger people in the room. And the TENS unit uses a 9-volt battery to produce a stimulus. what's one of our first responses? If we bump our elbow, we bump our head, our first instinct is to rub the area. One of the reasons we do that is we have fibers that carry touch, and we have fibers that carry pain to the spinal cord. They're different fibers. The ones that carry touch are faster. So when we rub our head, the touch fibers actually make it to the spinal cord first and block the pain from making it in. And so the TENS unit can actually work in that same manner to help cut down acute inflammation. We have some patients who aren't sleeping well because they've been in a car accident or they threw out their back. The TENS unit can be a wonderful tool for them because it's non-pharmacological, non-addictive. Never seen anybody hold up a 7-Eleven for a 9-volt battery for their TENS unit. And very safe. There are certain things that can happen with the TENS unit. I've never had it in my years of practice happen with a patient. So TENS unit is another tool. These days, you can get everything on Amazon. You want a new knee, you can probably get one on Amazon. But they sell TENS units on there. They're ranging anywhere from $200, and if you want the one with the disco balls and the Wi-Fi, you can spend up to $250 or so. But they're pretty readily available in today's shopping environment. One of the biggest challenges I see is this fear avoidance behavior. So somebody gets injured, and then what they want to do is just rest it. And there are times, if there's been a serious injury or a fracture, obviously it's not the time to go hiking South Mountain. But if we have an injury, starting to move faster, not faster, but starting to move sooner is going to benefit us. Has anybody here had an ACL repair before? We had an ACL repair. 20 years ago, you'd wake up and you'd be in a leg cast up to here, and you'd stay in that for 6 months, 3 to 6 months. Doesn't sound like a lot of fun. Today, you wake up and you're in a passive motion machine, moving you through ranges of motion. So as we've learned more, we understand that if we're going to recover from something like an ACL repair, movement sooner is better. And what ends up happening with acute patients is they stop moving. I'm just going to sit on the couch and rest it for a week. Personal example, I was helping my jiu-jitsu instructor move. Whatever the hottest weekend to date has been in Arizona was that weekend. So, and late June, July, whichever one it was. And being a guy, I didn't ask for help to move a love seat over the little hump in the moving truck. And I really tweaked the left SI region, low back portion. And it still helped him move. I had to be much more careful with the moving. And it was one of those scenarios where as we drove in the truck and got out of the truck, like I had to slide out of the chair, out of the truck, and had to move and warm up a little bit. Helped him the next day. Luckily, I had one of the instruments that I use for treating patients at home, so I already started treating myself. Got worked on Monday and Tuesday, and actually was training again on Wednesday. And had I just sat on the couch and waited for it to go away, the recovery may not have been as fast, and it may not have been as complete. So it bothers me at all, not at all at this point. And it was pretty sore, especially after I've been sitting down. But one of the things was I didn't stop moving. I was very careful with the movements that I did, but I didn't stop moving. And one of the things that we do in society is we rest, we ice, and we throw anti-inflammatories at it. There are a couple other things. Any providers in the room, we look at what's called the low PAM score, patient activation measure. And when a patient comes in, within a couple visits, I can really tell whether they're more likely to become chronic or not. And it has to do with the patients. I have those athletes that come in that go, I don't care what you need to do, but I have a marathon to run or a triathlon. I'm in the Ironman tomorrow, and I want to train, and I want to be in it. As opposed to somebody who comes in and goes, oh my God, I think I need to be off work for the next 12 years. And those are opposite ends of the spectrum. The athlete is going to want to do whatever it takes to get better, and they're going to get better. The people that are higher on the PAM score are the people that are less likely to engage in their own health behavior. So instead of going, well, what do I need to do at home to get this better faster, they're just kind of waiting, riding this out to see if it gets better on its own or with little interaction on the patient's part. The situation like this, and it's very easy in a research standpoint, but these people generally would be better served if they got into some type of therapy early on in their pain stage. I put on CBT up here just because CBT is pretty well researched. It's not that other forms are not effective. As a provider, though, the challenge I always have is, so somebody comes in for their first visit, and I can kind of detect that they're going to be a little bit high in a PAM score, and I say, so have you considered seeing a therapist? It's not an easy conversation to have for a new acute patient. If a chronic patient, it's a different story. Most chronic patients would benefit from some type of therapy to help manage their condition and again get them back on their lower down in the PAM activation score. So then, those are things you can do without any type of intervention. So from this point, we're going to kind of move on to what do we do to start getting people, if we're going to go to see a different type of provider to help us do this particular episode. The goal of any provider is to properly manage the acute episode and keep it from becoming chronic. Getting patients better, quite frankly, is not difficult. Most patients in our office for an acute episode, 2, 3, 4 visits, they're back to 100% or close to. And that's the goal. But part of my goal, I'm always trying to get patients to be doing the things that they need to be doing. So I had a new patient come in last night and really sedentary at work, doesn't exercise, and she wants to get better. But if she wants to get better from this low back pain that's been around for 20 years, she's going to have to start taking a part in her own recovery and starting to move. So part of that with an acute episode is to reinforce to that patient that that everything's going to be okay. This isn't going to be anything bad. I do a lot more talking people off the ledge than anything, letting them know that this isn't a big deal, that this is going to be fine. This is not going to be something you're going to be dealing with for the rest of your life. When we start getting that into our heads, it starts becoming, our likelihood of becoming chronic goes up. A couple other things we look at, something called fragmentation of care. In other words, when there's more hands in the pot, more providers kind of, oh, I went to PT and then I went to my primary care doctor and he sent me to pain management and I got x-rays and then I had to go to the pharmacy. Anytime you start fragmenting care and have more hands in the pot, it is very clear that that care is going to have worse outcomes and be way more expensive. So provider types that can kind of narrow things down are going to be a much better scenario. Did anybody see any of the ODOs that used to be? They do manipulation, and if you needed any medication, they'd be there. Those have kind of really gone by the wayside. There's not a whole lot of DOs that adjust anymore. But those kind of doctors or patients hardly ever left their office because they got what they needed in a single place. That type of care is well documented in the research to be a more effective type. As I mentioned, positive responses should be seen within 1 to 3 visits. This isn't you're done, but you should be looking that provider in the eye going, I definitely feel better. Maybe I have to be done, but I'm in the right place. And it's not 3 times a week for 10 weeks to maybe see if you're getting better. You should know very quickly if what is happening here is right for what's going on with you. Yes?
So what kind of injuries are we looking at that they should be better in 1 to 3 visits?
They're not better,
okay.
But you should start noticing a difference in 1 to 3 visits.
Oh, okay.
Positive response. So in other words, if somebody comes into me and they've really pissed off their low back, even after that, when they leave, 9 times out of 10, I expect to see them feeling better when they leave.
So you're talking about back pain? I'm sorry,
Anything.
I come from emergency, and I see all kinds of
yes, and it can be fill in the blank.
Yeah.
If it's a headache, if it's, and it's actually pretty rare, like in our practice, that somebody doesn't leave feeling better, even if it's for a couple hours. So that tells me we're on the right approach. The hard one is I've had patients who 3 or 4 visits go by and they're not feeling any better. My confidence in being able to help that patient goes down dramatically. And so that's what I'm talking about. It doesn't mean that they may be done, but they should be coming in and going, you know, I definitely feel better. I'm sleeping a little bit better. I have less headaches. It doesn't mean it's done. even though sometimes it is. But it means that whatever treatment you're getting is making a dent, even if it's just for a couple hours, because it means we're on the right tissues, we're doing the right things. So most of the research is on spine. Non-surgical spinal episodes are the #1 cost driver of insurance. I was on the provider advisory panel for United Healthcare for about 7 years. So they'd fly us out to Minnesota. I always tried to talk them out of that February meeting because they had a San Diego office. Didn't make any sense to me. But Minnesota in February. And you learn a lot when you're on those panels. And one of them is that their largest cost driver is non-surgical spinal care. Not because of the per episode cost, but because of the volume of claims that they get. I would have thought for sure that it was oncology, that it was cardiology. It was not. Orthopedics is the #1 group, and within that subset, it is non-surgical spinal complaints. So there's a reason why a lot of the research we see is on spinal complaints, because they're a large cost driver. But these same responses should, whether we're talking about carpal tunnel or plantar fasciitis or knee pain, those same responses, regardless of the body area, you can feel, should notice a difference. The other thing to remember is that any provider intervention is only a small piece to recovery. This does not mean that you shouldn't seek care, but a large part of recovery is going to happen by things that you do. It's not a matter of, I'm going to go to this provider and they're going to fix me. They're only going to be a small part of the equation for me getting better. And that's an important thing to remember. So then we start looking at pain management, anesthesiology. Obviously, we're looking at invasive, but the highest risks of any of the non-opioid management, that kind of makes sense if we're starting injecting things in the spine or using different pharmaceuticals, there's more risk. Should never be considered first line. I have a patient I'm dealing with now. It's coming in, and it largely is looking like a shoulder problem. And so they treated her shoulder. It wasn't getting better. And so they did an MRI of the neck and found a disc bulge. So now they're going to do an epidural. She's had no treatment to the neck. Her symptoms are not consistent with a disc bulge in the neck. I think that's just an incidental finding. She's got a shoulder problem. But now, as a first-line therapy for this neck problem that she doesn't really have, they're suggesting epidurals. It is not the course we should be taking. And so certainly I've kind of educated her about the positions that we should be taking. It's likely she's still going to go through at least one course. And we'll see. I don't expect very good outcomes from that. It's not appropriate for what condition she has. Other things like trigger point injections. The nice thing about trigger point injections is they'll usually put some lidocaine in there, and those can provide immediate relief. Now, it doesn't always fix the problem, but it means that that trigger point may have been a large generator of your pain. And so if that trigger point works and you feel better, even if for a short period of time, we now have done a really good job of targeting where that problem is. Now, it may take a little bit more time to actually, trigger point injections actually have therapeutic benefit as well, but it's not going to be in a single injection. It's going to take a little bit of time. But if you see immediate relief, you know that you're really on the right tissues. So epidural steroid injections, short-term effectiveness for lower extremity involvement only. So if people have pain going down into the leg or into the arm, if we're talking about the neck, then epidurals have some decent research on them if other things have failed. For axial back pain, so just the neck pain, like this particular patient isn't having any pain associated with the disc bulge in her neck. So they're basically giving it because she has a disc bulge on MRI, not because she has neck pain. Same thing with patients who have localized low back pain, so there's nothing going in the leg. I've had lots of patients have them over the years, and they generally don't provide long-term relief. If somebody has, I've got a patient right now that is not responding well to what we're doing. We're about 6 visits in, and she's got the leg pain. We've got her scheduled for an MRI Saturday morning, and there's every likelihood that we're going to have some type of epidural pain management done for her. She's not responding to what we're doing, and we want to get her better. It's not like, if she hasn't responded in 5 visits, 5 or 6, it's not like 7 or 8, it's going to be miracle treatment. But if she does the epidural and it helps, that now becomes a window to do other things. So if people are feeling better, then it's the time to go find a yoga class or start walking or hiking or doing more stretching. Because it's highly likely that that intervention is only going to be temporary until you start incorporating other things. Interestingly enough, it actually increases the likelihood of later surgery. Some of that may be because of the mindset. Like this particular patient with the disc bulge in her neck, she is now thinking that she has a disc bulge in her neck, even though it's asymptomatic. But she now has this in her mind that, oh my God, I have a disc bulge in my neck, and I'm going to get epidurals, and if that doesn't work, then oh my gosh, I might need surgery. It's asymptomatic, but it starts people on that trajectory. So I said a lot of times I'm talking people off the ledge, and imaging puts them on the ledge more than anything else does. RFA, radio frequency ablation, when it works, it generally works well. In these scenarios, if you ever heard it talk about, oh, they're going to go burn out my nerves, they're not burning out the nerves, they're burning out the insulation, the myelin sheath around them. And so that nerve won't conduct very well from point A to point B. And so it can actually help block some of the pain cycle. Ultimately, that myelin sheath will regenerate. And so a lot of times those pain will come back. But it gives you an opportunity to start feeling better and to start moving around more. Interestingly enough, RFA also later increases the risk of later disc degeneration. Part of that's probably just because you're reducing feedback. And so the body likes the nervous system. There's certain conditions where if the nerves get damaged, you can actually get joint degeneration. So it's probably something along those lines where it causes joint degeneration. Massage, the research is solid on massage for short-term benefit of acute conditions. Unfortunately, there's a wide variety of skill level across therapists, and sometimes the best way to find a good one is to go to one and see if that works for you. It's not like there's a lot of resources to go for, Google best massage therapist. It doesn't mean they're the best massage therapist, they've just done the best job of search engine optimization, so they're found. Just like anything else, not going to be able to fix any single visit. A massage, like a lot of PT or chiropractic, is very personal. So switching, like going to massage envy and going to a different massage therapist every time is not likely to get you the same benefits as it would be if you went to the same therapist again and again, because they get comfortable with you and how things work and how deep they need to go. What I mean by not going to be able to fix in a single visit, there are some massage therapists that, same thing with personal trainers. You ever been to a personal trainer who thinks that their goal is to make their new client not walk the next day? That's not a good approach from a personal trainer. We don't want to beat our patients up so bad that they can't walk for the next 3 days. But some of them have this in their mind. Well, there are some massage therapists that think, I'm going to go as deep as I can because I want to show this patient that I can really help. That's generally not a good approach with massage therapy because you can do too much. And then the patient thinks that it doesn't work and they derail and they don't continue with treatment. Acupuncture. Research continues to accumulate for musculoskeletal conditions. So acupuncture is another one that's been around for a while. Safety is very high for acupuncture. Not a whole lot of deaths associated with that. You can get like a pneumothorax if they're really bad massage therapists, they puncture the lungs. Generally not a lot of fatalities with those, but the safety in general is very high. Practitioner experience is likely a large player in outcomes, just like anything else. You can have somebody who just came out of school, and you can have not the stereotype, the little Asian guy that came over from, and he can acupuncture you from across the room and get it in a nice tight grouping along the meridians. So there's a difference in provider experience. And just like anything else, there's an art to practicing, and an acupuncturist who's been in practice for a long time will have a much better feel for what somebody needs. Mounting evidence that it actually works on fascial points. I was trained in acupuncture, I just never got licensed in it because it wasn't a passion of mine. And we're starting to understand the fascial system a little bit better. It's a system of the body that we haven't really appreciated. And there's a first International Fascial Conference was at Harvard maybe 5 years ago or so. And all of a sudden we had these people coming from all over the globe. We had the acupuncturists, you had the Rolfers, you had the Graston people, you had the Stecco family from Italy. And all of a sudden they're all in the same room going, well, I'm working on this. It turns out that there's a lot of cohesiveness between the research that they've been doing. There's just never been a common forum for them to bring those together. So the Stecco family is out of Italy and has developed a technique called fascia manipulation. And the fascia is kind of the sheath that we're entirely covered in. It is right down to the cellular level, so it covers all our muscles, our bones, our organs, even our nerves, and sometimes the cells themselves. It's integral to what we are. Some people call it the stuff, but the reality is it's a very important part of everything that we do and move and pain. So the Stecco family started to realize that we've known that there are planes within the body, flexion, extension. And so there are planes that are well associated with the fascia. And there are areas around those planes, especially where they overlap, where the body decided to put down an increased density of receptors in that area. So you look at where these fascial layers cross and you look at it under a microscope, and wow, there's a lot more potential for feedback from those areas. So if those areas become thickened because of an injury, you now have less feedback. Less feedback means my joint may not move quite the way it's supposed to, may produce joint pain that's actually coming from a fascial point that's not giving enough feedback. So the Stecco family has identified these using clinical treatment, cadaver studies, and looking under a microscope, and there's a very strong correlation between these fascial points and acupuncture points. So it is likely that acupuncture is a thousands of year experiment of truly mapping out the fascial system in an anecdotal way. So physical therapy, looking at things like modalities, ultrasound, interferential are generally more geared towards acute. These types of approaches like ultrasound and interferential are not going to help all that much for chronic conditions. They may help with an acute flare-up in a chronic condition, but you can interferential somebody until the cows come home, which is usually like 5 o'clock unless they get stuck in rush hour. But those modalities are not really going to have an impact on chronic conditions. Exercises, teaching people to move. We had a conversation before class about learning to move and how to manage your own condition. It's probably where their strongest point comes in, is the ability to teach people to move and to foster the idea that they need to move. Because that's a lot of what physical therapy is about. It's about teaching people to do exercises and to move. You're seeing a lot of providers increasing the use of dry needling. Again, we're going back to those fascial manipulation points. Instrument-assisted soft tissue mobilization has much faster responses. In the chiropractic world, Graston has been around for probably, I've been certified in it for probably about 12 or 13 years. There are other things like iStim and ASTIM that are use little pieces of instrument, either they're plastic or stainless steel or some variation of them. But the outcomes with treatment when you start using instrument-assisted soft tissue is interesting and far better than it would be from just adjusting or just exercising alone. The problem with PT is only about 6% of them will manage with a single EIN. Meaning that if somebody goes to them, they are not likely to just stay in an office. The PT is going to need to send them back to primary care or to pharmacy or to imaging. And so again, we start getting more of that fragmented care. That 6% number is from United Healthcare's numbers. And that's an Arizona number. So I know the numbers of where they lie in Arizona. Typically, again, not able to provide relief in a single visit. We're looking at a longer-term approach, deciding to kind of balance things out and get people moving again. And it's not likely that it's something you're going to leave that visit and feel better after the first one. Again, safety is very high. So chiropractic, I clearly have biases when it comes to chiropractic care, and I have concerns when it comes to chiropractic care, so we'll talk about that on the next slide. It's typically assumed that chiropractic equals manipulation, but more commonly includes rehab, home instruction modalities. So chiropractic is not a procedure, it's a a discipline that looks more at what can we do for the body to heal itself. Rapid outcomes, as I already mentioned, it's not uncommon for somebody to leave the office, and I see it all the time. They're like, I actually feel better. Like they're astounded that they feel better. I'm like, well, that's what you came here for. And so those kind of outcomes are not uncommon. I worked for a couple years when the Susan G. Komen was here, the 3-day, and we worked on in the medical tent in there. And it's pretty cool sometimes how much relief you can get to these people that have been walking 20 miles for that day, and then they're going to do 20 miles the next day. Interesting enough, United Healthcare's published data on, again, non-surgical spinal cases. They followed 14.7 million episodes over 3 years. So this is a lot of episodes of non-surgical spinal care. $25 billion in healthcare costs. Manipulative therapy, which is largely done by chiropractors, but manipulative therapy in general, was the only service that, when not provided at any point in the treatment, led to worse outcomes. It's the only therapy done that, when not included, will lead to a worse outcome for the patient. It's a pretty strong statement. Despite that, only 28% of patients in this study actually got to some type of manipulative provider in the first 10 days. It means 72% didn't. The nice thing is that 70% of the cases were handled with a single EIN, meaning that when they went into the chiropractor's office, there wasn't any fragmented care, that it was streamlined and didn't refer out for imaging or pharmacy, obviously not pharmacy. So, and again, we've got non-fragmented care with that. So the problem is, if manipulative therapy is not provided in the first 10 days, less than 7% of the time was it implemented. And the later it's implemented, the less positive outcomes it has. Interestingly enough, Dr. David Elton from Optum, who manages the chiropractic physical therapy portion of United Healthcare, was on a conference call maybe 2 months ago. And it's unpublished data as of yet, but they've been following this cohort of patients for the next decade. And 10 years later, there is a reduced use of opioids in the groups that went to chiropractic care. 10 years later. So it's a durable reduction in opioid use. So, and in studies, chiropractic care consistently shown the lower medication uses includes opioids. If a DC has seen early, less than 20% of their patients ultimately got meds. And if they were, it was later in the game. Unfortunately, there are certain downsides that there are with any type of therapy, and there's realities associated with chiropractic care. There's a high variability in practice styles. You've got some people that just treat the spine, and so if you go at patients who went to go see a guy who just does the spine for an elbow problem, it's not going to help that much. And so if they go see them for 6 visits and it doesn't get any better, well, it wasn't going to, because they weren't addressing the elbow, and manipulation on the elbow is not really all that effective. We need to get in there and work on soft tissues, but there's a high variability in practice style. So keep in mind that United Healthcare's numbers are based on the entire pool, not, oh, well, we just did this out of the providers that were really good, or did this technique or anything like that. If you happen to see a provider who considers chiropractic as more of a religion, then it's probably something you should run from. If they're suggesting you should see them 3 times a week for the next, I don't know, until the next solar eclipse, then it's probably not something you should go for. I consider patients in my office, it's like a giant game of name that tune. So remember, name that tune. The faster you can name that tune, the more likely you will win. So when patients come in, I'm like, if I can get you better in 3 visits, that's the goal. So it's not good for business, but ultimately it's good for the patients. And so anybody who's looking at that, and the whole idea, if you're set up for 3 times a week and you miss a visit, you need to catch up that visit this week, none of that makes sense. And yet there's a lot of my colleagues that continue to promote that. So if you get any type of that attitude or idea, and they want to set up a 32-visit care plan, when after visit 2 you may be feeling much better, makes no sense. So you want to make sure that their goal is to get you out of the office as fast as possible. Patients should notice a difference within 2 to 4 visits. Goes back to what we talked about, reducing the likelihood of response without this. I had a patient, she was in from out of town, visiting her father in Sun Lakes, had mid-back pain. Yeah, she had some other comorbidities, other things going on, but it worked on her, and she was used to some aggressive work, so I ramped it up pretty quickly. By visit 2 or 3, we really weren't getting any response. By 4 or 5, and I was working pretty deep, it wasn't really making a dent in anything she had going on. And I sat down, I said, you know, the likelihood of us helping you beyond this is not high. And she appreciated the communication, but at that point I need to start looking at something like, it'd be an unusual presentation for gallbladder, but gallbladder can refer to that right area, an unusual disc presentation. So she was going back to Massachusetts or wherever, somewhere on the East Coast where she was from, and I suggested she finally go to a primary care doctor, get a cervical MRI just to see if it might not be an unusual disc presentation. But she didn't respond, and it wasn't like more visits she was going to more likely respond. If I didn't see a change early, it probably wasn't going to happen. So extremities, headaches not nearly as effective with adjusting only. Oh, sorry, I missed the bullet point. So most effective, this is my bias, combines manipulation with soft tissue work. Whether that would be, in our office it's Graston, there's a lot of different soft tissue techniques that can make a drastic difference in outcomes when they're combined with manipulation. Extremities, headaches not nearly as effective with adjustment only. If somebody's got really tight suboccipital muscles and it's contributing to a headache, adjusting can help, but it's likely to only provide a temporary relief. Until you can get in there and relax the muscles on top of everything else, with adjusting, that's most likely going to be your most powerful tool. As far as safety goes, it is true that there is an association with manipulative therapy and stroke. However, a large study out of Canada looking at millions of patient visits found that that same association was there for primary care visits. So in other words, yes, people who saw a chiropractic, or people who had a stroke, there was a higher association that they had seen a chiropractor recently. That same number had seen a primary care doctor later. In other words, there was something going wrong, and they were finding somebody to try to fix them. We just got blamed because we worked on the neck, even though logistically, it's not likely that you can actually induce a stroke from the neck. I do believe it's possible, but the numbers are pretty rare. It doesn't mean I've had patients come into my office over the years that I was not going to touch until I got better information. Remember a nurse's aide at school, elementary school, never had problems before, walked out and got debilitating, extremely sharp neck pain. There is no headache associated with that. There is no way I was going to work on this patient until I got more information. She had already been to the ER, she had already been back to her primary care doctor, and they had ordered, they made sure she wasn't having a stroke, so they did brain MRI or CT scan. They did a neck MRI, but nobody did an MRA, looking at the blood vessels of the neck. If she happened to have a dissecting aneurysm, where her blood vessels in her neck were starting to separate out, which she was, her case was matched that, none of those imaging would have picked that up. So we got the MRI. It turns out it was clear that was not the case, but I felt much more comfortable adjusting her after I had that information. However, should that patient present and I didn't rule those out and it was a dissecting aneurysm and I adjusted her, there's a good chance that I would have just made things, she was already not on a good path, but I probably accelerated that. So I do believe that there is a chance, you see in the rare cases that the adjustment could be causative. But I also think a lot of that probably has more to do with misdiagnosis of the front end than it does the actual manipulation. So, any questions so far? Okay, we're moving to chronic from here. And the chronic animal is a little bit different. I think most likely that it's an acute injury that was never managed properly. And so it ends up going. Now, some injuries are just too severe, and there's going to be some chronicity associated with them. But I think most cases are acute cases that just weren't properly managed on the front end, so they end up becoming chronic. Again, early identify biopsychosocial factors early in address. So if somebody really is having those, again, first visit may not be the time to say, hey, have you ever considered having therapy? Because that'd probably be the last time they would be in my office for suggesting that they need therapy, even though that may be true. However, with chronic patients, it's a little bit of a different story. Somebody with chronic pain is going to have issues with depression and anxiety, and those patients would almost always be better served by having on their team somebody that manages those from a psychological standpoint. Patient has to be an active player in their recovery. If they're not willing to change, it's not likely that their story is going to change, that they are going to be a chronic pain patient. If they're not willing to start moving around and being more, they're going to be dealing with the same amount, and it's probably going to ramp up over time. Movement has to be part of the treatment. Things like yoga and Tai Chi. Yoga is very bad for our business. We recommend it all the time, but it's bad for business. And I can't tell you how many times over the years I've had patients who, like, oh my God, I haven't seen you in a couple of years. Oh yeah, I've been going to yoga. And then they stop going to yoga, and then they're in my office 2 weeks later. So I'm a huge fan of yoga because it gets the body moving in different ways than people normally do. Tai Chi fits into that as well. There are no quick fixes for chronic pain. We want them, patients want them. They want to, we're going to try to supplement with this drug or this injection or this treatment or this provider. I'm going to fly out to Kentucky because I heard this guy's really good. The odds of that one therapy being the godsend is very small. It happens, but it is not likely to be the average chronic pain sufferer. So they need to understand that this isn't a quick fix. I see it a lot. I've got a book, if you guys notice, I have a book on migraines and epilepsy. And I've had lots of patients who, they want that quick fix because they're having a headache. And they need a quick fix for that headache. But the reality is they need to start instituting lifestyle changes so that their brain is in a better space. They're doing more brain-friendly things. But they don't. They want that acute fix. And so 6 months later, had they been doing the things they would be doing, they wouldn't be back again with the acute headache. Or still, actually, with the acute headache, because they frequently don't just go away like that. So if patients understand that this is the beginning of a process, and yes, you may have a really acute headache today that we're going to manage in whatever way, whether it's going to the ER, whether it's going to urgent care, whether it's coming to our office, but ultimately, your answer needs to lie with changes that you are going to make. Because that's what's going to give you the benefit in the long run. It's not going to be what I'm going to do today. And migraines are a different animal. The true migraines really require lifestyle changes. But the bottom line for chronic patients, there are no quick fixes. So the problem with medication, in almost all cases, risks outweigh benefits in chronicity. I mean, certainly we have things like gabapentin, Neurontin, Lyrica that have their list of side effects. We already went over NSAIDs as far as those risks, especially with long-term use. But what that means is that certain situations like turmeric, it's a different conversation with the patient. So if I have a patient who's coming in and they're taking, it's crazy, 2,400 milligrams of ibuprofen a day and have for 6 years. And it happens. It's not 1,200, it's 800 or 1,200. And so now all of a sudden, if we're having a conversation about something like turmeric, it's a different conversation. Because now I'm not worried about the $30 you're going to spend on turmeric. I'm worried about the heart attack or the stroke or the joint degeneration or the ulcer you're going to have from the ibuprofen that you take there. Much different conversation at that point. But patients appreciate that conversation because a lot of times they're not even aware of that. One of the things I've seen over the years too is I firmly believe that, I've already mentioned that anti-inflammatories block the healing cascade. I've had patients over the years that have been on high dose, generally ibuprofen, naproxen, anything in that class, and they never seem to resolve. So what ends up happening, they come into me, they're taking, in one patient in particular, 2,400 milligrams of ibuprofen a day. And when she first started coming in, it was mainly for low back pain. Now, she's been a patient for 15 years, still takes just as many. She has had an ankle fusion. She's had both knees replaced. Her hips aren't great. She's got neck problems. and headaches. Nothing ever really resolves. And I firmly believe that the anti-inflammatories, the high-level anti-inflammatories, are a player in her body never really being able to kick inflammation. So she just starts accumulating these complaints. And her and I have talked about it. It will be a new conversation. So turmeric, the most recent meta-analysis did look at the research, did find that there was a benefit at 1,000 milligrams per day. I was just talking to Letty's 86-year-old patient that I have, a little tiny lady, was in a car accident. She's lucky to be alive. She was in a bad car accident in the 60. 20 years ago, ended up with a low back fusion. I do not believe that the other person in the car made it. And so she's lucky to be alive. She's fiery and just wants to not hurt. And it's great that somebody at 86 wants to not hurt. And so one of the conversations we just had is that like turmeric or any type of anti-inflammatory mix, they're not likely to completely get rid of everything. But they can make the difference between a comfortable day and maybe sleeping through the night and not sleeping through the night and not having a comfortable day. So that's what I usually say. These kind of things just fill in the gaps and take the edge off of the pain. And in general, the research on turmeric, in the next slide we're going to get into a couple more, is actually pretty good. Glucosamine is another one. Most research has been done on the knees. I generally don't think of it for spinal conditions. There hasn't been a whole lot of research on spinal. But the research is generally pretty good. Most recent actually looked at that it slowed the loss of cartilage volume. In other words, if you've got a knee problem, your doctor says, oh my God, it's going to need to be replaced, which is one of the patients I had to talk down on the ledge today, and I kept pulling her back from the ledge. She kept creeping back, saying, but I'm going to need to have my knee replaced. I'm like, no, you're not. And if you are, it's going to be in 30 years. But it was because she had x-rays and her doctor told her that she had degeneration. She was probably going to need her knee replaced in the future. So to her, in the future meant tomorrow. So I had to calm her down from that. But if we can slow the loss of cartilage volume, so in other words, we're maintaining the health of that cartilage longer, then that knee is going to last longer. It's going to be better and create less problems over time. What I usually tell people to do with supplements, especially glucosamine and chondroitin, is start with the pricey stuff. Don't go cheap on these items. Then, if you do notice a difference, usually 3 months or so is a good window, then try the cheap stuff. Because sometimes if you start with the cheap, there's obvious quality issues with some of the lower priced ones. If that doesn't work, you don't know if it was the quality or if it was the actual compound that didn't work. If you start with the pricey stuff and it works, then you can try the cheaper stuff. If you start with the pricey stuff and it doesn't work, it's not likely that the cheap stuff's going to help you. So I usually tell people that bite the bullet for the first 3 months, spend $30 on a good jar of glucosamine, and you're out $100 if it doesn't work, but now you've kind of ruled that out to really see if it makes a difference. And that goes for the turmeric and other things like chondroitin and ginger. Chondroitin's another one, actually August 10th, so what's today, the 17th? So last week, 800 milligrams a day comparable with Celebrex for knee osteoarthritis without the nasty side effects like, death from a heart attack. And chondroitin is not that expensive. A lot of times they're found in glucosamine combinations. But this is from a week ago that it was comparable to Celebrex, which is way more expensive. And we already know from 15 years ago or so that it absolutely increases the risk of a heart attack. Ginger is another anti-inflammatory. Most recent study review found it effective for chronic pain at 1 to 2 grams per day. Again, this isn't going to take somebody from bedridden to volleyball, but it's going to help. These combinations are going to help start taking the edge off of people. Another one is essential fatty acids, fish oils, generally better for inflammatory pain. Somebody's got like rheumatoid arthritis, but they control inflammation well in the context of dietary changes. So you can't be eating chips with omega-6 fatty acids like they're going out of style and expect fish oil to completely counteract that. We'll talk about that a little bit on the next slide. I usually tell people to give a 3-month trial at 1.5 to 3 grams per day. And you have to label shop. Most tablets, fish oil tablets, are a gram. But if you look at them, some of it is glycerin. So you may have anywhere from 200 milligrams to 700 or 800 milligrams in that capsule. So then you have to do the math to get up to 1,500 to 3,000 per day. Yes?
If you can't take the fish oil, is there another fatty acid that you can replace it with?
When I say fish oil, we really mean DHA and EPA.
Okay.
In general, if somebody's got an allergy, a good quality should not have any of the proteins in it that somebody would react to. That being said, you can find DHA only because the fish don't make it. Just like we don't make it, the fish ultimately get their fish oils from eating algae and plankton. And so those are where the DHA ultimately comes from. So you can get DHA supplements, they're generally pricier. But if you look for a vegan fish oil supplement, it's usually a DHA type product, even though vegan fish oils.
Would flaxseed oil be in that same category?
Flax is generally not. Not that there aren't benefits from flaxseed, but for inflammation, I usually steer people more towards the fish oils, the EPA, DHA. If you want to look at things like prostate cancer risk and heart attack risk, then flaxseed has its own benefits.
Right.
But generally not as powerful for inflammation as the fish oils are. So, can't have a discussion about chronic pain without at least touching on the cannabinoids. So, the research on cannabinoids has been around for a long time. The endocannabinoid receptor is what for cannabinoids, those are the THC and CBD generally found in marijuana, and it's also found, cannabinoids are found in a lot of other compounds. Echinacea has cannabinoids in it, so there's other compounds, it's not just unique. Hemp oil is another one. And the problem with it, there's a ton of research on the endocannabinoid receptor and synthetic versions of cannabinoids. But there's not been a lot of research on things like dosages and how we ramp up and contraindications because there's been so much fear about doing research on them. The research that has been done is generally quite positive. And I firmly believe that most of the evidence points to a central mechanism. In other words, it's working on the brain, not so much as an anti-inflammatory. I'm perfectly happy to be proven wrong in the future. And I've had patients that they swear by the creams, which would not really have a big effect on the brain. So I'm open to being wrong, but at this point, I generally consider cannabinoids work on the brain. Which, if that sounds strange, think about things like Lyrica and amitriptyline and gabapentin are working on central mechanisms in the brain. Pain is our experience with what we're feeling. And so we all know that we have good days where everything's going right and you accidentally took a chunk out of a brick wall with your elbow and you're like, yeah. And then you have other days where, holy cow, everything's going wrong, you woke up late, your car had a flat tire, you ran out of gas, and you just barely nick it, and it feels like somebody amputated you from the arm down without anesthesia. That difference is our perception up here. And there's very solid research that CBD in particular affects up here. And if you calm down that aspect of it, you start controlling some of the anxiety that's associated with pain, and patients generally do better. The nice thing is that hemp oil also contains CBD with very little THC. And I said most of the anti-inflammatory actions occur within the brain. So a lot of controversy obviously surrounded with that. As a non-user, I can talk somewhat objectively about what the research says on cannabinoids. So then we look at diet and managing inflammation and pain. It is one of the more powerful tools that we have. There is no doubt that a diet can be pro-inflammatory or anti-inflammatory. It's something that for a long time, a lot of doctors were not willing to wrap their hands around. There's not really any discussion anymore. Our dietary choices can drive or block inflammation. we know that I generally consider inflammation as a giant set of dominoes. And we've got one or two dominoes that are the key. So if you tip this one down, and this compound is called NF-kappa B, if you tip it down, it may block things like the arachidonic acid mechanism and things that like aspirin and ibuprofen and even turmeric or ginger work on. Because once you start knocking down a domino, it starts knocking down them all. And so now you have the first one and you've driven more inflammation. Well, keep in mind that what knocks down this first domino, NF-kappa B, it's lifestyle. And so I pictured another expanding row of dominoes out through here. And so if we knock down a single domino here, ultimately it can tip over NF-kappa B and start the entire cascade of inflammation. And there are foods that we eat that can actually sit on our DNA and change the way it's expressed. So the foods we're eating can actually drive or protect against inflammation. It's a pretty strong player. So when you put that McDonald's Big Mac in your mouth, think about what messages it's sending to your very DNA that makes you what you are. Or if it's that broccoli, what kind of message is that going to send? It's obviously going to be a different message. When we're talking about diet and inflammation, a lot of times we're talking about the omega-3 to 6 ratio. Neither is good or bad. It's all about balance between them. And so we want to increase our intake of the healthier fats and decrease our intake of the less desirable fats, or the things that we already have too much of. So things like raw nuts, avocados, wild fish, game, all are higher in high quality fats. Things like macadamia nuts, almonds, walnuts, pistachios. You have to make sure though that you're not having nuts with added oils. A lot of times they'll add cottonseed oil or peanut oil or something to them, which is high in omega-6s. So you thought you were doing good things, and it turns out because if you're eating Blue Diamond or something like that, it has these oils added and you're undoing all the benefits. I had a patient quite a few years ago. She really had a good lifestyle, but she couldn't bring her cholesterol down. It was sitting around 240 or so. And we looked at everything, and she was really doing a lot of things right. All we did was switch her from, she I think it was like Blue Diamond, or nuts with cottonseed oil. She switched it to raw nuts. The cholesterol dropped 30 or 40 points in 3 months. Because those oils were driving the inflammation, or the cholesterol and the inflammation associated with that. And our omega-6 are things like corn oil, sunflower oil, soybean oil, peanut oil. It's not that they're bad, but we get way too much of it in today's society. So starting to increase our intake of healthier fats and decrease our intake of unhealthy fat can be anti-inflammatory. A couple other things to consider is wild-caught fish. So unfortunately, I don't know that I've ever come across a non-farm raised tilapia.
No, you won't. You won't.
And so they generally feed them, in farm-raised salmon, they generally feed them corn, which I've done some snorkeling. I've never seen fish eating corn in the wild. So it's not their natural diet. The other thing that's important is when you buy grass-fed beef, is you need to make sure it's grass-finished. A lot of people make the mistake of going to Whole Foods and spending a lot of money on grass-fed, grain-finished. So the last 3 months, they start loading up with corn and everything, and you've just changed the ratio back to something you don't want. So if you're going to be doing grass-fed beef, make sure you stay with grass-finished. And that was somewhat theory until there was a study done maybe 3 or 4 years ago, and they found that inflammation markers were higher in the grain-finished versus the grass-fed, grass-finished animal product. High phytonutrient, low calorie diet. In other words, phytonutrient plant-based compounds, we want to take in more of those, as many of those as we can, in the context of a lower calorie intake. So always making sure that whatever's crossing your lips has high value and as low of calories we can get to. The example, like at our office, we have an espresso machine, and I play barista at lunch. So I'll do a double shot of organic French vanilla espresso with cinnamon, organic cacao, top it off with ice and dark chocolate. dark chocolate almond milk. It's about 80 calories, but it is chocked full of healthy protective things for us. Versus, not that we don't go to Starbucks, but you see those people come out with the giant, like I think they have a size now that comes with a dolly. See these teenagers coming out with it. Don't forget the whipped cream. So they're coming out with 900 calorie drinks and downing those. It's a while the espresso actually has value, we diminished it all in the amount of calories we take. So anything that we're eating, trying to pay attention to what kind of value it has. No refined carbohydrates, so that's rich wheat flour, high fructose corn syrup, sugar, anything that's been processed, we need to avoid. They're absolutely pro-inflammatory, and there's nothing in them that are good for us. Minimize animal-based proteins. It's another one. I'm not a fan of a vegetarian. We don't live a vegetarian, but we definitely live a plant-based lifestyle. And pescatarian, don't forget that too. For years, I just thought that was a new religion. But it's vegetarian people that eat fish. And usually those people are fine for ethical reasons. So we eat higher quality meats, but lower quantities. So my wife and I may split a 6-ounce grass-fed filet mignon, and most people are looking going, well, that's the appetizer. It also means that we're spending a lot less money on that higher quality meat because we don't need the quantities. So, and it also means like in a given day, I may not, if I have something for breakfast, I may not have any animal products for breakfast or lunch. And then for dinner, if she makes something that's, even if it's 50% animal product, the entire day has not been. It's been plant-based. So we think of that, but it's not a hard lifestyle to adopt and to follow. Okay. Any questions so far? So we'll move on to more provider-type interventions. So pain management and anesthesiology should be brought into play when conservatives measures have not been effective. Things like trigger point epidurals, medial blocks, RFA, we talked about them with acute, same challenges with them. But now the benefits, any potential benefits, can balance out a little bit more of the risks than they could in an acute situation. Even more important, and I mentioned this, for the patient to be an active player in recovery. If they're going to have any of these procedures done, it's not to just have this procedure. If people start feeling better, it's the time to start moving. And all too often, they're not told that, and they're not promoted to do that. They just think, oh, I'm feeling much better. Well, it may not last unless you start participating in life. Start looking at some other things. Some of the regenerative interventions, still new, not as much research in some of these. Most of it's anecdotal. Had patients in my office that have gone through different types of approaches. Prolo is probably the oldest one. Basically injecting what's called a sclerosing solution to initiate inflammation. So they use like a little bit of sucrose, a little bit of sugar solution, and inject it into like the MCL or the ACL and designed to create a little bit of inflammation for the body to kind of get out of that cycle and repair it. And Prolo generally, patients I've had have done well with that. Again, the data is pretty sparse, but promising and safe. Most recent review is in this year. And as research begins to accumulate, it's likely that we're just going to continue to see the same thing. And I generally think of Prolo for extremities, so things like elbows, wrists, knees. I have a patient that has done some Prolo for his spine. Not dramatic results, but over the past 6 to 8 months or so, he's done better with the Prolo that he had in his low back region. We're starting to get even more cutting edge with things like stem cell growth factor treatments. Hyaluronic acid doesn't necessarily fit in this category, but I put it in this category. That's been around for 15, 20 years or so. Your Synvisc, there's a couple other, Hylogen, there's a couple brands that are out now. I remember when I had my first patient, I had that done probably 18 years ago or so. Insurance didn't accept any of it. She had to buy it somewhere from Canada probably. And she had her orthopedic surgeon inject it. And she actually did well with that. I think that some people will do okay with this, some people not so much so. Generally not a downside to it. So long as sterile procedure is done, I don't know that I've ever had a patient who's gotten worse with these types of procedures, and some have got better, some have not. The nice thing is that insurance generally does cover these now. PRP and platelet-rich plasma. Research on the knee is favorable. And so PRP is a situation where they take your own, they'll draw off blood, spit it down, and use the stem cells from the plasma to re-inject. The idea now is those stem cells can help regrow some of the tissue that's there. The next step beyond that, if you've heard about things like placental-derived, non-placental-derived stem cells, fall into the category of orthobiologicals, and PRPs kind of fall under that category. So if you've heard people talk about stem cell, sometimes it's stem cells from some other source, sometimes it's your own. When it's your own, they're generally referring to things like PRP. And some of the initial data on this is good. This is one of the reasons why I tell patients that they need to put off, if they're considering having a joint plate replacement, you need to put it off as long as you can, because there's some stuff coming down the line that has some interesting potential. I have a patient who had just sent her a message today because she had told me, astute patient, sometimes you get patients that don't recall things very well. She's a well-educated patient. She went to California, spent $5,000 on stem cell injections in her hip. They told her to take it easy. She was on the slopes 30 days later. But 2 years later, she's actually doing well, very happy with the procedure. She had told me that there was some regression of the arthritis on imaging, which is astounding. And I have another patient that just came in now that we're talking about that because her left hip is pretty well degenerated. She's in yoga, she's ideal body weight. So her and I talked about this, and I want to really get confirmation from my patient that she actually had regression on the arthritis. So I just sent her a message. So if I was teaching this class in a week, I might have a different answer. But that's very interesting if that is actually happening, because that changes the game entirely. But once you've had a joint replacement, it's obviously not an option. For now, though, these remain largely cash-based and pricey for the average patient. While the initial damaging is promising, it's really worth a shot for most people if finances can be worked around. My patient in California spent $5,000 on the injections. She had the other hip done and spent $1,000. The outcomes were not as good. That's why she went back to the same clinic to get an injection in the left side, the other hip that she didn't have done. Yes.
Do you know, was that PRP or was that the placenta?
No, she had the stem cell.
Okay.
So massage research is not as supportive for chronic as it is for acute. Likely has more to do with the skill of the therapist. Like it or not, they're not all really skilled. That goes for PTs, that goes for surgeons, that goes for chiropractors, that goes for anything. And it is likely that the more skilled therapists with more experience are going to do better with chronic conditions than the average massage therapist. Again, that's somewhat of my bias, but it's also, there's not a lot of research one way or the other on this. Acupuncture, again, less research on chronic conditions. If you're going to do this, it requires more time, more visits to determine if it's going to work. So this isn't a 1 to 2 to 3 visit thing. This may be a full, 12 visits to see if it's going to be able to help with you. And again, just like anything else, more chronic conditions require more experienced acupuncturists. Physical therapy, unfortunately, I did some data crunching for their research for this. I couldn't find anything on any new data on chronic pain. The last one was in '97, which, if my math is correct, was a decade ago. I already mentioned that those modalities are usually less effective in chronic settings. However, getting patients to move helps with the regression from chronic. You just need to, as providers, need to make sure that we're not developing dependency in patients. So I have patients that go for their water therapy 3 times a week, and they're billing insurance for that, when in reality the patient should be doing less and less of this in an office and doing more and more of it outside. So. any type of approach for chronic is going to have to require soft tissue. Exercises alone are not likely to produce lasting benefits. But by the time some things become chronic, those tissues become more locked up. We've got fibrotic changes in the fascia, and exercises alone just can't overcome that. And you combine that with things like specific exercises or yoga with soft tissue treatments, and the outcomes are likely to be much better. And again, any therapist needs to understand the multimodal concept and promote movement of the patient outside of the office. So it's important to get them moving here and getting them understanding that they can move and that movement is a good thing. But ultimately, they need to work on transition. I remember I had a patient a couple of years ago, and she had had laminectomy in her low back. And her doctor, her surgeon, had told her that she's not really going to be able to move very much or exercise. So she's, at the time, she was mid-30s and was still having a lot of pain because she wasn't moving. So it took me several visits to convince her that she needed to start moving around. And guess what happened when she started moving around? She started feeling better and better to the point where it really wasn't bothering her anymore. Not only that, but she had some overlying depression, which contributes to the chronic pain, and exercise can then help with the underlying depression. So by telling her to sit on her duff and not move, the surgeon was feeding both the chronic pain and the depression. Not a good outcome in the long run. So chiropractic, again, non-specific low back pain, effective for self-reported pain and functional limitations. This was a study done this year. As I said, adjusting only is not as likely to be a benefit as a multimodal approach. Addressing the soft tissue, getting the patients to exercise, dietary changes, natural anti-inflammatories. But adjusting alone is that's a scenario we'll see somebody who's been going for 3 times a week for 6 months. And like, well, I feel a little bit better for a little time. After 6 months, you need to have longer lasting response. Same concerns that I talked about with acute treatment and there with chronic. And again, my bias is that combining soft tissue with adjusting gives you some of the best outcomes we can have for chronic pain. Questions so far? So on acute management, my bias is that no injury should be ignored, even if it's just for a single intervention. And again, that's my bias. But when I injured my low back moving, it wouldn't even cross my mind to not have that work done. I had Dr. Pangmer work on it twice, and like I said, by the 3rd day I was ready to go train again. There's no way I would have just let that go, because I understand the process, and I think that's, even if it was just a single visit, just to get things moving again, and make sure that anything that's locked up and tight is moving as the patient starts moving. Our traditional approach to acute injuries is not likely producing the best outcomes. That means the rest, the ibuprofen and the ice, and then throwing opioids. I can't tell you how many times in my practice I've had somebody who went to urgent care, they got Percocet or Vicodin, and they come in, they didn't want to take it or whatever, they took it, it didn't really seem to help, and literally in 10-15 minutes, whatever pain they had is almost all gone. And then 1 or 2 more visits later clears that up. I think we've really mismanaged a lot of the acute, which is why we're dealing with so much of the chronic problems. Again, moving as soon as possible. I gave the example of the ACL repair where you wake up from surgery and you're now you're in a device moving you through things. Gives you an idea of how fast we want you moving after an injury. For spinal pain, again, the data suggests that manipulative therapy introduced early is going to give us our best outcomes. Talking about chronic management, most potential for good outcomes lie with the patient, not with the provider. The provider acts more of a coach. You need to be doing this, this, that. Whether the patient does it or not, it's all in their ballpark. They just need to visit a provider who's going to give them information about things that they should be doing. Recovery from chronicity is not a passive process. And that is probably the most important take home, is that if the patient expects to get better, they're going to have to be an active player in their recovery from a chronic scenario. Multimodal approaches, no single approach is likely to be miraculously effective. A provider, any provider that you see needs to understand these concepts and not foster a dependence on the provider. So, any questions? I explained everything completely. Okay. Well, thank you guys for coming. I'll hang around for a few minutes if anybody has any additional questions or something they want to ask in front of the group. But again, thank you very much for coming.